thanks again for everybody joining us here. I am Susan Rogers. I am the president-elect of PNHP and an avid single-payer Medicare for All supporter. And I'd like to welcome you tonight as we talk about a little bit about lobbying and talking to Congress people and just trying to convince those that can legislate for single payer why they should go for that. So I'd like to introduce our panelists. First, we'll start with Alankrita Siddula. Did I pronounce that right?
Yes, you did. It's pretty phonetic.
Okay, all right. All right, but you like to go by Krita, so that's what we'll go by. Okay,
Yes.
so I know from Rush, where she is a medical student, she's now a rising senior planning to go into surgery, and I wish you luck with getting that residency. But she's been very active with the SNaHP chapter at Rush, and she was very much a big part of the AMA demonstration to try to convince them to support Medicare for All. And then we have Rachel Madley, who is from New York, who I have met on several times. And she is actually an MD PhD student studying immunology, but she'll be graduating next spring. And she's been in New York doing a lot of work on the, with the chapter there on single payer for the state. And then we also have Dr. Carol Paris, who I know well too, who is the immediate past president of PNHP, who is living in Nashville and is an activist, a very active activist for single payer, who has gone to jail fighting for single payer. So I don't know if that's public knowledge. We all know that. So why don't we get started? And we can just start with you, Krita, and you can tell a little bit more about yourself and your journey into becoming an activist and lobbying and talking to legislators and how you got involved in this.
Yes, hello. So as Dr. Rogers said, I'm at Rush University. I began my work with SNaHP my first year of medical school as the president of the Rush chapter. But since then have gotten more involved in organizing with the Chicagoland SNaHP Coalition and the AMA Action, and now I'm currently an executive board member for the for SNaHP National. I got involved with legislative lobbying actually after hearing Dr. Paris speak at a PNHP meeting about talking to her congressman and convincing him to sign on to HR 676. And so I decided I wanted to give it a try. And at the same time, another fellow SNaHP member, Paul Ehrlich, a fourth year at Midwestern University currently, has started a letter campaign that he wanted to share with representatives. So we decided to organize meetings. And over the past year, we have met with 5 representatives in the Chicagoland area. We use it as a chance to just establish a connection with them and their office to begin to understand what they think of single payer Medicare for All and exactly what their hangups up, why they hadn't signed on yet, and to really figure out where they stand so we can address those issues that they have moving forward. And in general, just to get them to start recognizing our names, SNaHP, PNHP, so as we forward them any material, they know they can think of us as a resource when it comes to healthcare reform.
Okay, great. Thanks for that. You've been very busy, it seems. Okay, Rachel, you want to tell us a little bit about how you got involved and what you're doing now and anything else we should know about you?
Sure. Thank you for the introduction. So I am actually also on the SNaHP executive board with Krita this year. And prior to that, I've worked a lot, as Dr. Rogers mentioned, with the PNHP and SNaHP chapters in New York on the New York Health Act, which would essentially be statewide single payer healthcare in New York. And through that, I've had the opportunity to help attend and also plan health professional lobby days, where we bring health professionals from across New York up to Albany to show our support for the New York Health Act, but also to meet with as many legislators as possible And we have done that pretty much for the past at least 5 years, but I think going back even further. And so just that continued presence and show of support has been really helpful. And also those repeated meetings with the legislators help us to build a relationship with them. And at those meetings, similar to what Krita mentioned, we like to discuss why we really believe that the New York Health Act and single payer in general is necessary. We also like to talk to them about their concerns, even if, you know, they're a co-sponsor, but maybe not super vocal about it. We like to talk to them about their worries and then follow up with them on those concerns and why they actually shouldn't be worried about that and give them really the facts. We also plan events in our community where we try and integrate the legislators into those events. So we hold town halls where we can kind of bridge the gap between legislators and community members, and the legislators are often invited to speak but also to listen, and that kind of bridges the divide of what we think a legislator is, who is usually removed from the constituents, and we really like to open up that dialogue so that the legislator can see, you know, exactly why the community really believes in the New York Health Act. And in New York, there is also on a much broader scale a coalition called the Campaign for New York Health, and that coalition has members like PNHP and SNaHP, but also hundreds of different community organizations. And through that coalition, there's been a real focus on making sure that we are constantly in the presence of the legislators and in contact with them and building those relationships. And that has been with legislators who may be on the fence. So we're constantly contacting their offices, providing new educational material, and just making sure our name is always popping up in their daily life, but also fostering a relationship with the lead co-sponsors of the bill. So both of the lead sponsors in the Assembly and the Senate, we make sure that we, again, are sharing materials with them, but also listening to what they have to say about the political landscape so that we as organizers can understand what's actually going on inside Albany, because as we all know, politics is often a little bit wonky and weird. So having that relationship allows us to understand and strategize, and it also works in an opposite direction. So having a relationship with our legislators allows them to understand what we as the community fighting for single payer really want and really need. And I think one example of that was the New York Health Act originally didn't include long-term care right off the bat, but the disability rights community really fostered the relationships with those lead co-sponsors and just kept their presence up, kept the pressure on them, and now long-term care is a part of the New York Health Act. So I think the two-way relationship is really important. And so I'm just really happy that I've gotten to be involved in these relationships and learn from all of the organizers in New York who started this work.
Great. So it sounds like both of you really emphasize the importance of building the relationship so that you weren't just a name talking about a particular topic. You got to know them and they got to know you too. Dr. Paris, can you speak a little bit about what you have done and how you see lobbying and talking to legislators?
Thanks, Susan. I'd be happy to, and I'm glad to be on with Krita and Rachel, and to see some of our other board members are on the call, and I hope they'll feel free to chime in with their expertise too. Building a relationship with a with a representative is one of those things that I had to learn how to do rather than something that sort of came naturally. Certain kinds of activism come naturally to me, and others I really have to learn and practice. And one of my teachers was Katie Robbins, who I think Rachel probably knows quite well. Katie is very active with the New York state effort, and so I think that's what I'd like to say is that for those on the call, if this is something that is not second nature to you, which it isn't for most of us, there really are some techniques and things you can learn to do that will improve your effectiveness. And we can go into that, you know, as the time goes forward. I think I'll stop there. We can learn how to do this.
Okay, great. So I assume all three of you learned how to do it on the, you know, the more you did it, the better you got at it, and you learned from your mistakes.
And I definitely learned from some mistakes with Jim Cooper as well, which I will get into later.
Okay, or you want to talk about that now? Dr.
Sure,
Pierce?
I can.
Sure. Yeah.
So I think my representative is Congressman Jim Cooper from the 5th District of Tennessee in Nashville. He is a Blue Dog Democrat, a moderate Democrat, and in 2017, he had not ever been a co-sponsor of Medicare for All. I started meeting with him, and in, I guess, around January, started attending. I had some individual meetings with him in his office with a group of people. We presented our position. He basically said it's not affordable, and we followed up with some information. But what really made a difference was seeing him repeatedly over time, also meeting with and talking to his health staffer, who I developed a relationship with, and kept sending him information. And the long and the short of it is that by March, I had an opportunity to up the game a bit, up the ante. President Trump was coming to Nashville, and this was, if you remember, in 2017 was when they were first trying to dismantle the Affordable Care Act. And one of the first, I don't even remember the name of the legislation that the GOP had, but Trump was trying to get our senators, Alexander and Corker, to sign on to it, and they had not yet. And so he did one of his rallies in Nashville, and the action I took at that rally is something that comes naturally to me. That part was fun. All this other stuff, learning the politics and knowing what game is going on is not second nature to me. But be that as it may, I went to the rally, I disrupted, I held a sign over my head and said, put your name on a plan that works, Medicare for all. And I kept chanting that until I was thrown out, and got a lot of, and I had, of course, someone videotaping it who uploaded it immediately to my friend, Dr. Flowers, who got it out on Facebook and Twitter. And that was the point. President Trump was not the target of my action. I was using him. The target of my action was Jim Cooper. I kept saying to him, Congressman, you have to understand, I live in your district, I'm organizing in your district, and I'm not going away. I'm not going to shut up. I'm not going away. And I already had a meeting set up with him about a week after this action. And so I go to that meeting, and he's the one who brought it up and said, so what was with that thing you did at the Trump rally? And I said to him then, you have to understand, I will do some outrageous things to get your attention. And obviously, if you've heard about it, you know that there was a great deal of Twitter and Facebook action for several days following that, and an article in the paper, yada, yada, yada. And it was at that point that he, at his next town hall meeting a week later, announced that he was going to co-sponsor HR 676. So my ego would like to say that I convinced him that Medicare for All was the right way to go. But the truth of the matter is, all I did was create a very awkward and uncomfortable situation for him. I was making it politically toxic for him not to get on board. And I think he just did the political calculus and decided that this was something he needed to do. So that was the good part. Here's the lessons learned, and here's what I failed to do. What I failed to do is keep the pressure on him. I did not continue to follow up with him in 18 and early 19. And so what happens in 2019? Jayapal is now the sponsor of the bill. It's got a new number, and Cooper decides he's not going to co-sponsor, and he won't have. We had a meeting with him. He was very dismissive. He lectured to us and wouldn't let us talk. And I think it was Rachel was talking about sort of the political landscape. Well, let me tell you, the political landscape had changed. He did his political calculus and decided he didn't need to be a co-sponsor this time around. And that's where we are right now. We have had people protesting in front of his office. I've written a few more letters that have been published in the newspaper, but he pretty much is not responding. So that's what I would say is one of the lessons I learned, is that you can't get their signature and then think, okay, check one and move on to the next. You've got to stay on these people all the time. You've got to be reading what the changing political landscape is and figure out what it is now that you need to how you need to pressure them differently going forward. Yeah, and I'd love to hear what Rachel or Krita had to say about that, or you, Susan.
Yeah, well, no, I was just going to comment on a couple of points that you made about how when you went to the Trump rally, what your focus was. It wasn't necessarily being anti-Trump, it was being pro-single payer. And I think that that's important with any kind of activism, to not get distracted, but just stay focused on what your point is. And so your message is always consistent. And I think to your comment about how the political landscape changes and a legislator may be supporting one thing this year, but then in his, with his constituents, things may change for them and he may want to focus on something different or whatever. And so you're right about having to keep the pressure off, because it doesn't, just once you've done it, it isn't done for good. It still has to be worked to maintain it. But Krita, let's hear from you, and maybe you can expand upon some interactions that you had where the people you were trying to convince weren't necessarily that receptive. And is there a way that you found out how to make it not bipartisan, but that this is the right thing to do regardless of your party?
Yeah, so as Dr. Paris said, politicians are very good at taking up the time. They like to speak, they're very trained in it. They'll lecture you with all these reasons that make no sense. when you're trying to bring the hard data. So these conversations are always difficult, especially under a time crunch. 15 minutes is not enough time to really get into the meat of why Medicare for All. So it can be very difficult conversation. So for us, what we do is we like to be as prepared as possible. We do our research on the representative, really figure out, first of all, is their seat safe? Are they really worried about being reelected? What committees or subcommittees are they on? What have they said about healthcare reform during that campaign and publicly, and what's written on their website? So we can pick up a few key points that we want to talk about in the meeting, whether it be financing, how the public option isn't enough, whatever relevant point we want to make according to what they've said in the past. So that way, if they start bringing all these other things, we can bring the discussion back to what we had already prepared and put out these key points that we want them to take away. Regardless of that, though, things do tend to go in different directions. And I think it's very important to just be persistent, as Dr. Paris said, but also in the meeting physically while you're there, to give them some space to speak and try to bring it back to a similar ground. One of the things we do at the beginning of a lot of our meetings with Democrats, at the very least, is to establish that we all believe that healthcare is a human right, and most of the time they'll agree, yes. And we just kind of defer on how we want to get this universal healthcare actually provided to the Americans. So that's where we can start figuring out, okay, your plan is this, Medicare for All is this. So establishing some similar ground lets them know that you're not being too aggressive and that you're willing to listen, but also making sure to stick to the points that you brought in, and then continuing the process after you left the meeting, follow up with them, mention the things that they said in response to whatever you talked about, and provide them the resources to counteract any misinformation or misgivings they have. So in general, just know your target, strategize before you go in, and always follow up with them after the meeting, and continue that relationship with multiple meetings, as it'll take some time.
Yeah, it sounds like follow-up is so important. All three of you, emphasized how important that is. Rachel, you want to?
Yeah, I think that was really well said. One thing I'll add on follow-up is, if you have someone who is a co-sponsor, you still want to follow up with them, not only to make sure that they don't fall off the bill, but also to keep pushing them. So if they're a co-sponsor, but the extent of their co-sponsorship is their name on the bill, in our mind, that's not good enough. We want you to be a co-sponsor and a champion for the bill. So we want our legislators to be super vocal about the bill. We want them to host events in their community about how this bill would affect people. We want them to be going to leadership and demanding that this bill move forward. So when you're thinking about, oh, I want to meet with my legislator about Medicare for All or your state single payer bill, but they're already a co-sponsor, so it's not worth it. It is worth it. You can always push them harder to make sure that, one, they feel the continued pressure, but two, that they step up to the plate even more. And really, you want them doing everything in their power for Medicare for All.
Right.
There's one other thing I would like to add too, and well, somebody in the question said, did Representative Cooper direct you to his health staffer? No, he did not. That's part of our doing our homework, is finding out who the health staffer is. And that was a relationship that I developed independent of Jim Cooper. It just so happened that his staffer at the time was somebody who I knew of because I knew another health staffer, and so that helped sort of make an introduction there. And I would call him up periodically and say, am I making any progress? Do you have any questions? What materials do you need to help you present the case to Congressman Cooper, because it's the staffers who do the lion's share of the research, and then they just sort of present the information to their member of Congress, who then, you know, puts that in the context of the political landscape. So, and following up, so that was the question. That was the answer to the staffer issue. It's always necessary, if you want to get an appointment with a member of Congress, you have to have someone who is the constituent in your group. You can have other people speaking as well, but if you don't have a constituent and you're trying to get a meeting, good luck. They won't even meet with you. So make sure you have at least one constituent in your group. And then following up with a written thank you and just a small amount of information that is very, very relevant to the discussion that you had that day.
Good point. Maybe
Don't overload them with 30 pages of, you know, all the FAQs from the PNHP website. Don't do that.
you were reading my mind, Carol, because one of the things I was going to ask the three of you to talk about was when you say you give them materials, because you're right, if you give somebody 30 pages, it'll just go on a stack of 50 other things that they plan to read, you know, by 2050. So it never gets read. But what kind of materials do you use that you think that they would read and be useful? Are they FAQs, or do you just give charts and numbers or express? I know that different things work for different people. I find some people are more responsive to looking at numbers, and some of this comes from getting to know who it is that you're talking to. But knowing that you've only got so many pieces of paper you can give them before they just stack it away, what kind of things do you hand out or email?
So for us with the New York Health Act, it's been around for decades, so the basics are usually familiar to legislators. So what we'll focus on is what's new. Are there new amendments and improvements that would make legislators more likely to sign on? And what's timely? So I think 2 years ago, there was a lot of talk in New York, and there still is, but about the labor movement and how they would be benefited from Medicare for all, but the thought was that they would be hurt by it. So we gave infographics and FAQs about how Medicare for all would benefit the labor movement. And this year we had a virtual lobby day, and part of our materials was a quick fact sheet. So just bullet points. You want to keep it short and sweet about how the New York Health Act would have prepared New York better for coronavirus. So at this point, the basics are usually known. So we try and do what's new. And then if there's a specific question asked in the meeting, that's when we'll send maybe a more detailed document. So if someone wants to see numbers about the budget for transitioning health insurance company workers, that's when we'll send more detailed notes in a follow-up email. But when we're just handing it out, we try and keep it short and what's relevant at that moment.
All right. Krita, you want to add to that at all?
Yeah, exactly. We always, since we've been starting our relationships with most of these representatives, and we're going to narrow down to the ones that we think we can most effectively sway. We always start off with the single pager on the Medicare for All Act and small summary documents like that to give to them, to give to the staffer beforehand or to hand physically when we're at the meeting. And then in our follow-up, we'll have more pointed information, whether it be on financing, exactly why public option wouldn't be enough or would not work, et cetera. So we also stick to that same kind of method. And I saw in the chat that someone mentioned sharing personal stories. One of the things we do in our first establishment meeting is share some personal stories. Of course, we make sure there's a constituent in the room and we share personal stories either as a patient ourselves or as a healthcare worker, to really show them why we're there and why we're passionate about this and give them the idea that we're going to keep on this because it's personal to us. It's not just work that we're doing. So I don't think it's necessary to do every single meeting, but we like to start off with that in the first meeting.
Okay, good advice. You know, one of the questions that was sent in earlier, someone asked about how will Medicare for All benefit rural hospitals because they live in a rural district and want to know how they should talk to their representative, specifically how a Medicare for All would help them. Because I think one of the
Well,
go ahead.
I have one sort of data point that when I read this, and I can't remember if it was on the Wendell Potter's Tarbell website or what, but it really hit home to me, so I'll share it. And that is that rural hospitals are generally the first place that a patient goes. And if, and especially with COVID now, with the pandemic, that's not likely the last place they go. What happens is they get sort of triaged in the rural hospital and oftentimes then transferred to a tertiary care hospital. Well, if you think about if this is someone who has a high deductible and who doesn't have a high deductible health insurance plan now, even, I mean, I would consider the plans on the exchange, the copper and silver plans, those are essentially high deductible plans. So think about it. The patient goes to a rural hospital and that's their first episode of care. That's when their deductible starts kicking in. And then they go to the tertiary care hospital. They've now they've incurred all the cost for their deductible at the rural hospital. The tertiary care hospital bills insurance and gets paid. The rural hospital is the one that gets stuck having to try and collect on an unaffordable deductible and copays. And so they're the ones who are always struggling with their accounts receivable. I don't know if I explained that. I hope I explained that well enough, but it's one of the issues that makes it really hard for rural hospitals.
Yeah, and then there's often the lack of maternity care too at some of these smaller rural hospitals. And so when women present there, they may have to be transferred somewhere else. And again, it's the deductible, and it's a significant problem in rural communities in terms of the bottom line, because most hospitals most rural hospitals, their margin is low. It's not like your big academic centers in urban areas that do high profit procedures and things, so that their profit margin is quite high and they have a base, and the other hospitals often don't have that, and so they can only withstand but so many situations like that. Let me ask something else about what is can each of you describe maybe a situation that just really stood out in your mind about something that just went really, really well because things just sort of fell into place, or a situation that almost said, I'm not doing this anymore? We've all had those, the really good ones and the really bad ones, and what you kind of learned from that. Anybody can go first. Krita, you want to go, or Rachel? Or nobody has a case like that that you can remember?
Well, yeah, I feel like in general, most of the meetings I have with representatives, I walk out discouraged. and annoyed and frustrated. And I need to remind myself that this is a marathon, that I'll not be able to change their mind within 5 minutes, that there's so many factors at play, and that being unsuccessful has nothing to do with my performance or abilities. As we mentioned, you know, politicians are incredibly well trained on how to speak and talk around these matters and give some BS responses that make no sense. So it's hard to bring the discussion back to the issue at hand. So actually, one distinct meeting I remember, we had been running late due to a snowstorm, so we were already off on the wrong foot. And thankfully, the office was understanding and the representative was there. So we started our usual spiel of trying to establish some similar ground. And because he was a Democratic representative and had been highly public about wanting healthcare reform and believing that, you know, all Americans deserve care, we started our usual spiel of like, okay, well, clearly we both think healthcare is a human right and everyone should be guaranteed healthcare in this country. And he just stops us flat and says, no, I don't think healthcare is a human right. And so we were not like prepared to deal with that statement. And we made the mistake of just trying to do this whole philosophical discussion on what he said, rather than getting back to Medicare for all and the points that we want to bring across. But thankfully, there have also been good movements. One of the representatives we spoke with was a nurse, so she had the context and understanding of like the nuances that make providing care difficult in our system. But it was really easy to tell that she was not a proponent of Medicare for all, because the position she was in, the district was very, it's usually very Republican. So it was very unprecedented that she had won that seat. So she was afraid of holding on to her position to create some real change for her constituents, and you know, had her usual reasons like, oh, the Congressional Budget Office doesn't give a value for this, I can't really trust that we'll save money, et cetera, et cetera. But I think further down the line, knowing that we're kind of on the same footing of understanding how our healthcare system does not work, and believing that every American should be guaranteed healthcare, if she's reelected and feels safer in her position, we can continue to work on getting her to be a supporter.
Good story.
Yeah,
I
can
had
just,
go ahead.
thanks. So I have two examples, one for each scenario. So on the discouraging side, in the New York State Senate, we have been about one co-sponsor short of a majority and for the New York Health Act, and it has passed the Assembly multiple years in a row. So I remember the 2018 election, everyone was really, really excited because the Democrats didn't have a majority in the New York State Senate. And so we felt that if we could get a majority in the New York State Senate, especially with candidates who ran on the New York Health Act, that it could pass finally the Assembly and the Senate. And I remember the election, we got the majority in the Senate, not only of Democrats, but of people who ran on the New York Health Act. So my naive and very hopeful mind, in my mind that night, I was like, this is it. This is the year. It's got to happen. There's a majority of people who ran on the New York Health Act. And unfortunately, a handful of the candidates who ran on the New York Health Act did not co-sponsor it, and still have not up until this day. And so that was super discouraging, because I know aside from our PNHP and SNaHP work, people outside volunteered for those campaigns because they were running on the New York Health Act, and then to have that kind of bait and switch was super disheartening. We're still one co-sponsor short, but I think we just had some really exciting electoral results, so I'm hopeful that it will pass. And that leads me into my good experience. Actually, it just happened recently. I had a meeting with a newly elected New York State senator and one of the staffers, and they sought out a meeting with us to talk about the New York Health Act from people who have been organizing about it, meaning people from the campaign and DSA, and organizations that have been on the ground fighting for it. And the purpose of the meeting was for them to understand what the landscape looks like from our eyes, and how this new senator can become a New York Health Act champion. So they're ready to get into office and immediately start pushing for this. And they're replacing someone who was a co-sponsor, but really in name only. And so that was really exciting for me, because now, before this person is even in office, they are ready to fight with everything they have for the New York Health Act. And I think them seeking this meeting with us didn't just happen overnight. It's a result of all of the organizing that has been going on, even way, way, way before I joined PNHP and SNaHP. But it's really exciting now that we are building relationships with even incoming legislators who are ready to hit the ground running.
Great. You sound very energized. That's good. And along that line, I'll ask, Krita and Rachel, what do you think we need to do to get more younger people involved in this? I know that a lot of young people aren't really thinking about healthcare because they're not high users of it, and they don't think that they'll ever really need it for anything significant. But you never know, and that's why we have health insurance, is to protect us from those situations. So what do we need to do to not just convince younger people to support Medicare for all, but how to get them active in the unit in the movement for this, and become an activist supporting Medicare for all? I know it's easy to get medical students because they're sort of, joined at the hip to this, but, for younger people who aren't necessarily in the healthcare field.
I think one way is to really point out how intersectional this issue is. A lot of young people are very, very passionate about racial justice, LGBTQ liberation, and all these other social issues that also have a component of needing healthcare and healthcare equity for these groups. So I think by connecting with groups that already do this work, and then trying to collaborate with them, help them with some of their actions and campaigns, and slowly form a relationship where you can educate them on how Medicare for All is also something that they should be working on for their groups. And I think that would be the best way to kind of get young people involved that are not medical students.
Okay.
We are definitely on the same wavelength, because I would say the exact same thing. And I even had in my notes, even the Sunrise Movement, which is a huge organizing powerhouse, focuses on climate justice, but they actually recognize that Medicare for All would be a part of that. And so I think, going to those groups and those largely youth-led movements would be super helpful. So I wholeheartedly agree with what Krita said.
Okay, yes, because no, Carol, Dr. Pierce, did you have
Yeah, I mean, when I was president of PNHP, one of the groups that we definitely collaborated with and supported their work was the Poor People's Campaign. And that sort of spanned all age groups, but these, talking to people who are poor and or Black and brown and poor is about all of the struggles that they have, and just including healthcare as another aspect of it. So we were there to support the Poor People's Campaign, not try to call a lot of attention to healthcare, but let it sort of come up organically. And it always does, because if you're poor and if you're a disenfranchised group, you're really struggling with health disparities.
Yeah, that's a good point. And I think that what has happened now with COVID and Black Lives Matter is that all of these issues, we've known that they intertwine anyway, but now I think that the connection and the relationship between all of these is made much more obvious to everyone who, even if they haven't been involved in any of these social justice movements before, but there's not isolated problems. They're all part of the same puzzle, and it's just trying to, I think we all have to kind of decide what we want to focus on, knowing that it's impacted by other things, and that's why it is important to work with other social justice groups so that all of these things get dealt with. And it would be nice if they could all just come together at one point, but this isn't fairyland, so, you know, well,
I wanted, Susan, could I ask Rita and Rachel a question that I would just like to know? And that is, you know, what are the most relevant platforms on social media right now that younger people are paying attention to? Is it still Twitter, or has that become passé? And are there other platforms we should be getting savvy with?
I think Twitter is still really popular, especially in issue advocacy. And I think Instagram is pretty popular too, especially among younger people. Even like I have younger sisters and they don't use Twitter, but they use Instagram. So I think it goes by age. And I know even as SNaHP, we're trying to have more of a presence on not just Twitter, but also Instagram.
Okay.
I'm not sure if Rita has other ones.
I am not good with social media myself. I know TikTok is a big thing that young people do. I don't understand how we can utilize that platform, but I think the mainstays of Facebook and Twitter are still like used by, you know, the younger generation. So there's still valuable platforms to use, but we'll see how long these other platforms like Instagram and TikTok stick around. But in the meantime, really adapting our materials to those platforms would be useful.
Okay, well, we're approaching, we said we would have this go on for 45 to 60 minutes, and we're approaching the end of that. Do others have other questions that they would really like to ask any of the panelists, either of the two students or Dr. Paris? And
hi, I am really interested in trying to do more advocacy, but at the moment I'm in a red state, and the times that I have contacted representatives, the response I get back is either, you know, just a rote message, or even on the phone, speaking with the staff, they're actually pretty dismissive, like, you know, like they don't care that I'm a constituent. And I'm wondering if anybody's had any success in like finding leverage points with candidates that are not of your party or whatever, and they're sort of politically aligned to oppose this cause.
that's a very good question, because I think unfortunately, you know, it's not a question of whether the representative cares about their constituents, as they follow the party line. And even if it's not, you know, so, I mean, it's like with Medicaid expansion, you know, a lot of people suffered from red states that did not expand Medicaid, you know, and they knew that they were hurting those people that lived there and depended on them, but they followed the party line. I think in this landscape, the way it is, it's a really difficult.
There are there's a couple of ideas that I have. Ed Weisbart does he's done a couple of webinars on making the conservative case for Medicare for all. And so, you know, just choosing your words carefully. You don't walk into a conservative's office and say healthcare is a human right, because that's like scratching your fingernails down a chalkboard for them. So you say, you know, I think it's in everyone's best interests to have healthcare because it's good for business, it's good for public health, it's good for the economy, and sort of make those cases. And you also could try, if you can get even an opportunity to speak at a chamber, a local, in their district, a local chamber of commerce or Rotary Club, and happen to mention, well, you know, when I spoke at the Rotary Club last week, blah, blah, blah. It lets that member know that you're talking to their constituents and you're hearing from his business community and you're educating his or her business community about the financial benefit of support for Medicare for all. Those are just some thoughts. Anybody else have an idea?
Those are good suggestions, Carol.
Yeah, I'll just go off of the point about attending Chamber of Commerce meetings. Also, just shifting your focus from legislative to organizing within your community. So I believe that voters who are conservative are easier to talk to and sway to support Medicare for all than politicians are, because like Dr. Rogers said, the party line is where the legislators usually stop. But especially right now, we're seeing growing support for Medicare for all, even in conservative voting groups. So it's not in the legislative sphere, but if you're able to organize your community, then you can demonstrate the pressure to this representative, and they may never sign on to Medicare for all, but it could create an environment where you could possibly flip the seat, or at least they'll understand that there is pressure so that they're not vocally opposing it.
Very good.
That's a great, that's an excellent point. Is that they just need to understand that you're organizing in their district and you're educating their constituents. And I think that when you're meeting with non-medical, non-legislative people, everybody's got a healthcare story. I mean, that is such a great place to start, is just get the person talking about their own experience with our healthcare system. Because you're going to connect with them on an emotional feeling basis. And then you're just pointing out, you know, your problem is really unnecessary if we had a national health program. And that gets people's attention. So especially when you're talking to, you know, the community, you really want to not even just tell your stories, but elicit their stories and then use their story to teach, to elaborate on it and educate.
This is John Crossan. I'm from Minnesota. I just wanted to make a few comments. First of all, I'm absolutely delighted to see Rita and Rachel. I have been working a long time for Minnesota to get the medical students involved in this, and we currently have 6 first-year medical students who are working on this this summer. So this is where I think the future is. The question I have of people is, should we be working on getting this Medicare for all passed on a statewide basis first, or should we continue working on trying to get this passed nationally?
Both.
The funding would actually be easier with a national program. And yeah, because, and then all the advantages that come from it being national, because a state program still isn't portable. I mean, I live in Chicago. If I go, 20 miles to Indiana, I'm not insured, because of my single payer only would apply here in Illinois. I'd like to see it done nationally. It'd be much easier to equalize and distribute services in a way that would be more fair and would address some of the inequities that are in the system. And I know that Vermont had a problem with the funding, and that was why they weren't able to enact their state single payer. That was one of the reasons why they couldn't enact the state single payer. But we're drawing to the end, and this has been a wonderful conversation. I have enjoyed this. I would like to thank my panelists for taking the time to join us tonight, and I thought that the comments and the insights were all excellent. And I learned things, and I hope everyone else on the call learned some things. And I'd like to thank all the people who signed up and joined our panel tonight and listened. And I hope everybody took home some good points and will wake up in the morning ready to be an activist and make some calls and all. Okay. Well, thank you again. And I'd like to say good night.